Delighted to be here. Thank you very much to CSI and Professor Bang and his team for the warm welcome to this wonderful conference. These are my disclosures. My task is to talk about various trials over the years about atrial fibrillation and how those have informed our management or understanding of atrial fibrillation. And of course, at the beginning, there was sinus rhythm. We're all born with it. So this is a normal rhythm that we'd like to be in. But when we go into atrial fibrillation, obviously that's an abnormal rhythm when the atria are beating very fast and irregularly and very inefficiently, and therefore it can come up with a lot of problems, as we all know. Atrial fibrillation is certainly an impending epidemic, and it is the commonest rhythm that we see clinically. In the EU, this is estimated in 2016 that the total number of people with atrial fibrillation who are older than 65 years old, this is the elderly population, is around 7 million people. And that's going to rise rapidly to about 14 million in 2060. If we look at the people over 80 years old, it is about 50% in 2016, and it goes rapidly to about 65 to 70% in the years to come. And that's because we are living longer. We are better in treating heart disease, cardiovascular prevention, and there's also improved socioeconomic prosperity. But elderly people, elder population are actually surviving with sicker hearts, and therefore there's greater prevalence of LV dysfunction, and with that, the prevalence of atrial fibrillation. These are the European Society of Cardiology guidelines for the management of atrial fibrillation, the ABC domain, thinking about anticoagulation, better symptom control, and also comorbidities and cardiovascular risk factors. If we look at the B section, in regard to managing symptom control, it is still, after assessment, looking at rate control first before rhythm control strategy. So this rate versus rhythm control debate has been going on for a long time. We can treat the rate, that means accepting atrial fibrillation but using various means to control the heart rate to make it acceptable and not fast, or we can take a rhythm control, which is to convert it back to normal rhythm. And that has been a debate for a long time, and up till the point of the ESC 2020 guidelines, all the trials were still leaning towards a no difference between the two, but arguably encouraging rate first, followed by rhythm control thinking. And that's because all the trials up till that point were actually suggesting that there is no major difference between rate control versus rhythm control. These are a number of trials around the turn of the century, and you can see that the meta-analysis suggests that there is no difference in all-cause mortality, no difference in stroke, and that was certainly true in a later trial, AFFIRM, in patients with heart failure. The rate control strategy was certainly no worse than a rhythm control strategy up to that point. If we look at the larger study, which is AFFIRM, which is an American study randomizing patients with atrial fibrillation more than 6 months and more than 6 hours over 6 months, and this is in US and Canada centers. They randomized 4,000 patients and followed them up for a number of years, and you can look at the risk factors there. These are patients, typical AF patients, and to the surprise of the investigators, I'm sure, there was no difference between rate versus rhythm control in cumulative mortality. And in actual fact, if you look at the lines, it probably suggests that rhythm control was faring worse, with more strokes happening in the patients that you were trying to restore normal rhythm. And that's because at that point, physicians are allowed to stop the warfarin if they achieve sinus rhythm or if the patients are well. And we find that a lot of the strokes are actually happening in patients who are not on warfarin. Warfarin was stopped, or they are subtherapeutic for their warfarin. So the main message that was learned from AFFIRM is that adequate anticoagulation is absolutely essential in the management of patients with AF and high-risk factors, even if sinus rhythm is achieved. And then later on treatment analysis demonstrated that the presence of sinus rhythm and the warfarin usage was conferring a protection. So with that in mind, that's also stuck with the medical literature and certainly stuck in our ESC guidelines even up to 2020. With that background, we were very fortunate in participating in this East AFNet 4 study, which is an international study coordinated by the German AFNet group led by Paulus Kirchhoff. We were very fortunate to be the UK lead center at Leicester, and there's 135 centers over 11 countries randomizing patients with early atrial fibrillation. That's atrial fibrillation within a 1-year diagnosis of atrial fibrillation diagnosed on ECG, randomizing them to early rhythm control using various means to achieve sinus rhythm, we can, versus usual care, which is at that time guideline methods is still rate control. So we'll follow patients up. The mean follow-up in the whole study was 5.1 years, and the results were, out of 2,800 patients that were randomized in 2 groups, there was a significant difference between usual care versus rhythm control. This is the first trial in 20 years to show data that supports that a rhythm control strategy causes a reduction in overall outcome, which included cardiovascular death, stroke, worsening heart failure, or admission with acute coronary syndrome, a 21% significant reduction in outcome there. So we're very happy with that, but I think the main question is how and why. The Framingham study has already shown us that atrial fibrillation confers an increased mortality in patients, maybe up to a 2-fold increase in mortality, and the majority of that happens within the first year of diagnosis, whether it's men or women and in different age groups. So certainly this early diagnosis, early treatment is an important factor. What's different between AFFIRM and EAST? Why was EAST positive? Things have moved on. In EAST patients, over 90% of patients were anticoagulated, so that's a major difference. And also, we were better in keeping patients in sinus rhythm. So if you look at AFFIRM, RACE, and STAFF, the patients who were actually in sinus rhythm at the end of follow-up was relatively low, whereas it's a much higher percentage there. There's a recent paper that looked back at AFFIRM and looked at patients that look like the patients in EAST within AFFIRM, and these are patients with a 6 months diagnosis within the AFFIRM cohort. They found 62% of that AFFIRM cohort fulfilled those criteria. These patients had lower all-cause mortality, higher comorbidities, but they didn't find any difference in the survival and the outcome there. So they did not find the EAST results within the AFFIRM cohort. What was different then? In the EAST and AFFIRM head-to-head, there was more beta blockade usage in the EAST, less digoxin usage, more flecainide, more dronedarone, and of course AF ablation was only available in EAST and not AFFIRM. So perhaps the refinement of AF therapy could be the reason underlying that. We also looked at the EAST cohort in patients with and without heart failure. There was no difference whether they have heart failure or not. The EAST result still stands, so there was a significant reduction in outcome with early rhythm control, with and without heart failure, with and without symptoms, and obviously different centers had different approaches to treatment. Intervention centers would use ablation first, non-intervention centers would use drug first. The result of the early rhythm control seemed to be entirely explained by the randomization group rather than the method that the rhythm control is achieved. So these were recent publications from EAST. Moving forward in more deep dive analysis of EAST, this is a 4-way decomposition analysis using an exponential model of 14 parameters of follow-up data at 12 months. And the single parameter that explained 81% of the outcome was the presence of sinus rhythm at 12 months. So if the patient was going for early rhythm control, it achieved sinus rhythm at 12 months, that was giving you the best outcome. But if the patient did not achieve sinus rhythm, then early rhythm control did not actually confer benefit. And the last, more recent analysis is actually looking at the CHA2DS2-VASc score within EAST, comparing patients with a high CHA2DS2-VASc score of 4 and above versus patients with a lower CHA2DS2-VASc score of less than 4. The majority of the benefit that is accrued of early rhythm control versus usual care is actually in the higher risk patient with higher CHA2DS2-VASc score, and that's published recently in Circulation. Adverse outcome actually was more in the early rhythm control in the lower CHA2DS2-VASc score group, interestingly, although this was not in the life-threatening events. So to wrap up, I think AF is certainly increasing in prevalence and incidence, especially with the increasing age in population. The new evidence supports a proactive approach with early rhythm control in patients with new onset AF and concomitant cardiovascular conditions. Achieving sinus rhythm at 12 months seems to be driving the majority of the benefit of early rhythm control, at least in EAST, and patients with higher comorbidity burden is more likely to benefit, a feature that we should be studying in a prospective randomized trial. I'm sure these features will be further elaborated in the next speaker, but with that, I think it is good to be able to restore sinus rhythm, and I thank you for your attention.